welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
And we have Celia Bressler. She's a PGY2 emergency medicine pharmacy resident at the University of Kentucky Healthcare. And today she'll be presenting on a randomized trial of drug route and out-of-hospital cardiac arrest, or the PARAMEDIC-3 trial.
So before we get into our specific trial, we're going to jump into a little bit of background information that sets us up for why this trial was done. So many of us are likely familiar with the intraosseous or IO access route, as it's a nice alternative to IV use in emergency situations when we're unable to get IV access quickly. It can theoretically be obtained in any large bone, but the typical locations are humeral head and proximal tibia, which is shown here in this picture. So the drug absorption occurs through the catheter being placed into the bone marrow, which has a rich network of blood vessels that allow for systemic circulation to be absorbed. Some resistance might be encountered with drug administration that requires pressure bags for fluids or extra flushes following medication administration, but the appeal behind IO access still remains that it's theoretically established quicker and in situations where IV access might be more difficult to establish or in patients where it's more difficult to establish. So this also prompts the question of, is it as effective for drug administration as the IV route? So the reason why we're so concerned about it is we want to give these meds quickly, since there's a lot of literature showing that administration is key for indicated patients. So the PARAMEDIC-2 trial was a randomized double-blind controlled trial carried out in the United Kingdom across multiple emergency response services. So they included adult patients, and they categorized that as 16 years or older, with out-of-hospital cardiac arrest and required advanced life support. Their trial was randomized for patients to either receive parenteral epinephrine or saline placebo, and this was also in addition to standard of care. Their primary outcome looked at survival at 30 days, and then they also assessed rate of survival until hospital discharge with a favorable neurologic outcome. So they found that the use of epinephrine resulted in a significantly higher rate of 30-day survival, but then they also noted that more survivors in that epinephrine group did have severe neurologic impairment. And that kind of prompted a discussion and hypothesis that maybe these patients with worse neurologic outcomes might have been influenced by other factors, such as delays in time to epinephrine administration. So that leads us to some secondary analyses. There were two notable ones done. So the first one that you see on the left was done by the initial trial group, which is why you see that name again. And they completed a planned secondary analysis of the PARAMEDIC-2 trial, looking at time of administration to epinephrine. So they did find that the rate of return to spontaneous circulation, or ROSC, decreased at a greater rate than placebo compared to epinephrine arm, but they also found that rate of survival and favorable neurologic outcomes was not substantially different over time between the two groups. So they stated that this basically just confirms that early treatment of cardiac arrest, such as chest compressions, defibrillation, rather than the specific administration of epinephrine, provides the best outcomes. And so this also prompts the question of, what if the route of administration matters? And that's what is causing these differences in outcomes. So then the second study on the right was carried out by Nolan and colleagues, which is a similar group to the one that did the initial PARAMEDIC-2 trial. And this was also an analysis that looked at IV access compared to IO access. In PARAMEDIC-2, IV access was established as soon as possible, and then IO access was allowed if it was not possible to do IV access after 2 initial attempts. So in their secondary analysis, they found that there was no significant difference between the two treatment groups for ROSC at hospital handover between the IO and IV group. But a note to make is they didn't document the site of IO access that they established in this trial. So next, there was an International Liaison Committee on Resuscitation Systematic Review, or an ILCOR systematic review, that was carried out to inform update of international guidelines regarding drug administration during cardiac arrest. So in their study, they had 6 observational studies that they found and 2 randomized controlled trials that had adult patients with out-of-hospital cardiac arrest requiring drug administration and comparing IV to IO access. They broke up their analysis between the observational and then the randomized controlled trials. Within that observational cohort, they concluded that IV access was favored and stated that this was with very low certainty of evidence, and this was also due to significant concerns for bias, particularly due to the fact that the need for IO access may indicate or patient or arrest characteristics that are risk factors for poor outcome. When looking at the randomized controlled trials, they found no statistically significant difference in route of administration and outcomes. But they do also note that only one of the observational studies and then one of the controlled trials listed the site of IO access. But then looking at where the EMS protocols were, most of the patients probably had pre-tibial access based on their protocol. So these studies kind of all led to the recommendations that are in the 2020 AHA-ACLS guidelines. And they state that based on these results from the previous studies, they concluded that establishing a peripheral IV access remains a reasonable initial approach, and they classify this as a 2A recommendation, but IO access may be considered when IV is not successful or feasible with a 2B recommendation. They also go on to state that further research is needed to assess the difference between IV and IO access, and then they also specifically list tibial and humeral for the IO access. So even more recently, very recently, in July of 2024, a multi-center cluster randomized controlled trial known as the Victor trial was published. And this study was carried out in Taiwan between 2020 and 2023, and they did have a temporary suspension from May of 2021 to July of 2021, and they noted this to be from the COVID pandemic. So they included adult patients with out-of-hospital cardiac arrest, but this study did exclude a larger variety of patients. Some of those patients that they did exclude included patients with any signs or symptoms of infection, and they also excluded trauma patients. They compared drug administration again between the IO and IV access routes, and they limited IV access placement to any upper extremity and any IO access to the humeral site. They did find that IO access did not result in different outcomes in relation to survival, hospital discharge, or neurologic outcomes. So in October of 2024, the IV-IO study was published, and this was a multi-center parallel group superiority randomized controlled trial carried out in Denmark. So they included patients with out-of-hospital cardiac arrest requiring vascular access and compared IV access to IO access again. So they further randomized their IO access group into humeral and tibial sites. And of note, in Denmark and out-of-hospital cardiac arrest, these are typically attended by the primary ambulance unit, but also a physician manned unit, which is something very different than what we typically see here in the United States. They also found no difference in sustained ROSC between the initial IO and IV access in adults with out-of-hospital cardiac arrest. And they also did something interesting and looked at CT scan placement of the IO sites, and they noted that 71% of patients had correctly placed catheters in the humeral group as compared to 100% in the tibial access group. And they also noted that there was a large number of patients that had bent catheters in the humeral access group versus the tibial access group. So these previous studies and hypothetical questions about which is the better route leads us to our current study, which is PARAMEDIC-3, that attempts to answer many of these hypothetical and unanswered questions posed by the previous literature. So jumping into PARAMEDIC-3, it was carried out between November of 2021 and July of 2024 in the United Kingdom. And it was a pragmatic, open-label, randomized trial that spanned 11 emergency medical systems, including 10 health service ambulance services and then 1 standalone air ambulance service. Due to lower than anticipated numbers of enrolled patients, they did have recruitment terminated early before their planned sample size was reached. So they included adult patients with out-of-hospital cardiac arrest that required vascular access for drug administration. They had very little exclusion criteria, and the one noted was a known or apparent pregnancy. So once these patients were identified for randomization, they were randomly assigned in a 1-to-1 ratio to receive either intraosseous first or an intravenous first strategy. The anatomical location of the IV or IO placement was decided by the treating paramedic on scene. And if access couldn't be achieved based on the initially assigned route within 2 attempts, the route of subsequent attempts was determined by the treating paramedic. And that strategy is similar to what we saw in PARAMEDIC-2 about the 2 access attempts and then switching over to whatever the paramedic thinks is best. So once the vascular access was established, all cardiac arrest medications were expected to be given by that route until either ROSC was achieved, resuscitation was terminated, or the cannula was dislodged, or the patient arrived at the hospital. The paramedics were also expected to follow the 2021 Resuscitation Council United Kingdom Advanced Adult Life Support algorithm. The algorithm is shown here, and in the algorithm itself, it's a little difficult to see if epinephrine is a flat recommendation every 3 to 5 minutes down in the bottom left, or if it is similar and follows our HA-ACLS guidelines. But within that supplementary appendix, it does delineate that epinephrine is given immediately for a non-shockable rhythm and following the 3rd defibrillation attempt for shockable rhythms, which makes this similar to the algorithm and treatment strategy to what we would see here in the US. So the primary outcome was survival at 30 days, and secondary outcomes included any return to spontaneous circulation, sustained ROSC, time to ROSC, and then neurologic outcomes as reported on the modified Rankin scale. And then they also assessed health-related quality of life in survivors via the EQ 5D-5L questionnaire, which is just something that kind of categorizes different areas of the patient's life, and then they have a scale of 1, 2, or 3 of how much it's affecting them. So based on the PARAMEDIC-2 trial, they plan to recruit approximately 15,000 patients. And then this was on a basis that the sample size of 14,972 patients would provide the trial with 90% power to be able to detect a difference of a 1 percentage point in 30-day survival between the IV and IO access group at a 2-sided significance level of 5%. They also planned to have 2 interim analyses to assess for efficacy or harm during the trial. They utilized an intention to treat approach for all outcome analyses, and the primary outcome was analyzed using logistic regression models adjusted to mitigate any confounding influences on survival, such as the one listed on the slide that we know can impact, such as bystander CPR and the initial rhythm that the patient presents with. Estimand framework was also used for the primary outcome for 2 intercurrent events, including the discontinuation of treatment before initiation to assign treatment, and then also for treatment crossover patients. Continuous outcomes were analyzed using linear regression models, and then also time to event outcomes were analyzed with Cox regression. So moving into what we care about, the good old results in PARAMEDIC-3. So one big thing to encounter and take note of in this trial is the crossover patient. So as we had mentioned earlier, patients who were unable to have randomized access established within those first 2 tries, the paramedic could then establish whichever access was most feasible for them. So if the use of a non-randomized drug route before the completion of 2 unsuccessful attempts at the randomization route was done, these patients were considered to be what they called crossover patients, which ultimately was a protocol deviation. And of the 107 patients in the IO group that crossed over, that got IV access, 88 were considered those crossover patients. And then of the 992 patients in the IV group who got IO access, they said that 369 of those were crossover. And so that gives about 9% of patients that had that crossover from the whole entire trial, and technically 9% of patients who had a protocol deviation. Again, this study analyzed based on an intention to treat analysis. So these crossover patients were included in their original assignment group for analysis. So there were 6,082 patients total enrolled, which is much lower than their anticipated of the 14,000, with 3,040 in the IO group and 3,042 in the IV group. The baseline demographics between the 2 groups were similar and reflect what we would expect in a US study, with the majority of patients being males, most common initial rhythm being a non-shockable rhythm such as asystole or PEA. These are very similar to the results from the cardiac arrest registry to enhance survival or the CARES database within the United States. One thing to note is this study did have high rates of bystander CPR. One recent US study had rate of about 60%, but within the Office of Disease Prevention and Health Promotion CARES database, it was reported that 37% of arrests in the US were witnessed in 2023, and bystander CPR was initiated in 41.5% of patients. So in this study, there's about 70% of patients with bystander CPR as compared to maybe a 41% in 2023 in the United States. For time intervals, they reported time from emergency call to EMS arrival, which again is similar in response time from in the US. And within the study, there were no differences in time to access or time to drug administration between the two groups. But of note, in a recent study in the US in Utah, the median time to vascular access is almost half of the time that is noticed in this study, which again might show that we get a little bit quicker access in the US EMS system rather than in the UK. They also didn't report time to defibrillation, which might have been a nice outcome, and that is why it is also not on my slide. So here's the breakdown of first successful access based on location in each respective group. The majority of patients in the IO group had tibial access rather than humeral access, and a majority of the patients in the IV group had peripheral access and some even central access, but mostly peripheral. And the noted IO patients that you can see within these IV group column here is due to that failed initial attempt or those crossover patients that remained in their initial assigned group for analysis. So for their primary outcome, they did find that 4.5% of patients in the IO group and 5.1% of patients in the IV group had survival at 30 days. They didn't find this to be statistically significant, and they found no difference between routes of drug administration on survival at 30 days. So here they did a nice forest plot of subgroup analyses for the primary outcome. As you can see, each result crosses one, and none are considered statistically significant, but it does show some trends within each group analyzed. In relation to sex, neither subgroup showed a significant difference, but the point estimate for female trends a little bit towards favoring the IV route. EMS witness arrest showed a trend favoring IO route, but again, very wide confidence interval. And then the non-shockable rhythms trend a little bit more towards IV, but none of these being statistically significant, just showing some trends that they had within their study. For secondary outcomes, although it was underpowered for definitive statements on its secondary analysis, it appeared that the percentage of patients with ROS were lower in the IO group than in the IV group, which could suggest drug efficacy was influenced by the route of administration. This is also applicable to the time to ROS between the two groups, but the authors did note they did not assess positioning of the IO axis, which could have led to suboptimal drug absorption if there were high occurrences of dislodgement. Although these results did suggest that IV access might have higher rates of ROS, there were no differences noted in survival to hospital discharge or favorable neurologic outcome. There was also one adverse event reported in the IO group, which was pain at the site for a longer period of time than expected, but they determined it not to be a serious adverse event. So ultimately, they concluded that among adults with out-of-hospital cardiac arrest who required administration of medications, the use of an IO access first vascular strategy did not result in a higher 30-day survival as compared to the IV first strategy. So moving into further analysis of this study, some strengths include that it is a large multi-system prospective randomized trial. Although in the UK, the way their EMS systems treat out-of-hospital cardiac arrest is very similar to how we would in the US based on their algorithm. When comparing 30-day survival for out-of-hospital cardiac arrest in the United Kingdom and in the United States, the rates are also very similar, which is a positive for being able to extrapolate this to patients within the US. Some weaknesses include that it was underpowered to detect a 1% difference for the primary outcome due to that slower than expected enrollment and early termination of their study. They also noted that they were unable to assess resuscitation quality, which is difficult to do in these situations in general, but could have considered implementing feedback devices for assessing quality of CPR and reviewing patient encounters to ensure appropriate algorithms were followed and appropriate medications were given. There were a lot of protocol deviations, so ensuring that the algorithms were appropriately followed and appropriate medications given for both non-shockable and shockable rhythms. Unlike IVIO in the Victor trial, this trial didn't have a standard anatomical location of either IV or IO access or any way of randomizing it. There was also, again, that significant amount of crossover between the patients, with about 9% of patients having protocol deviations. With the intention to treat analysis, this patient population remained in its original assigned group, but the authors did try to implement statistical analyses to correct for any adjustments this could have made. And lastly, there's limited external validity due to it only being within the United Kingdom. Although many basic factors such as 30-day survival are similar, other factors between the two locations can be very different, such as ethnicity and race, which they reported in their trial as well, with only 2% of Black African American patient population. A recent US study also had much quicker time to administration of epinephrine than in this study. And ultimately, they're really good concepts that can be taken away from this study, but with all of these extra factors in this weakness column to consider and keep in mind as well when interpreting the results. So some of these key takeaways that we can take away from PARAMEDIC-3 include prioritizing IV access on arrival to the hospital if able and if feasible. If IO access is the only access available, either you or someone familiar with the IO access site should be able to assess the integrity of the site to ensure no obvious dislodgement. Although this won't always give definitive confirmation that the site is sound, it does provide an initial look to make sure it isn't completely unreliable. And ultimately, this study again reinforces that prioritizing proper medication selection and dosing when access is established is most important, and prioritizing basic life support measures such as quality CPR. So with that, I will take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.